Good afternoon, everyone. Welcome back to week 6. This is our final week of our Retention Planning and Strategies, Behavioral Health Edition Learning Collaborative. My name is Suzanne Spear. I'm the Director of Workforce Development here at ACU, and we are excited to have you back here, for our final edition focused on team-based care. So we're going to jump right in today, and we're just going to go over, as usual, we're going to go over our webinar housekeeping. So keep in mind that we are recording this webinar, and it will be available for download on our discussion board if you'd like to revisit there. And as well, you can feel free to ask questions along the way of this broadcast. You can do that by either raising your hand and putting it either in the chat or questions box. And we will have some dedicated question and answer time at the end. And we'll be sure to get to any questions that you might have. If you have any technical difficulties or if you need anything specific to logging in or audio or things like that, feel free to email Mariah Blake at mblake@clinicians.org, and she will get you pointed in the right direction. So today we are talking about team-based care, as I mentioned earlier, and we have a great team that is going to be presenting with us today. So we have an all-star cast from CHC Inc. And first we have Amanda Shizzle, and she is actually the project director for the National Cooperative Agreement that Community Health Center Inc. has, and she oversees the implementation of all of the clinical workforce development initiatives there at Community Health Center Inc. We also have Dr. Veena Chanamsetti with us today, and she is the Chief Medical Officer at Community Health Center Inc. And she has been with them since 2007. So, and rolling out our team is Dr. Tim Kearney, and he is the Behavioral Health Director for Community Health Center Inc. And he has been with them since 1998. So we've got a wealth of knowledge on the line. We're so excited that Community Health Center has agreed to partner with us on this learning collaborative as we finish up our series on retention and focusing on strategies for behavioral health staff and how that works with team-based care. So without further ado, I'm going to hand it off to Amanda, and she is going to take us through the first part of our presentation today.
Thank you, Suzanne. Good afternoon, everyone. As Suzanne just said, my name is Amanda Shizzle. I'm the Project Director for the National Cooperative Agreement on Clinical Workforce Development, and I'm going to give a quick introduction and overview of who we are, and then we'll get started on the content. So just speaking about our NCA, the Community Health Center Incorporated and the Weitzman Institute, which is our research arm, provides education, information, and training to interested health centers on transforming teams and training the next generation. We put that through a variety of formats, but specifically national webinars and participation in learning collaboratives. We also focus on residency training and hosting health profession students in health centers. Community Health Center Incorporated was founded in 1972. We deliver care across Connecticut. We served over 100,000 patients last year through our network of comprehensive primary care health centers, school-based health centers, healthcare for the homeless. Our emphasis is on clinical excellence. It's the core to everything that we do. And the goal is that we deliver the best care possible with the best outcomes. And we wanted to disseminate this information and this knowledge. So CHCI created the research and development arm of the organization, the Weitzman Institute. This work has brought us across the nation through our various programs, such as the National Cooperative Agreement, as I just spoke about, our Weitzman Echo, which is focused on high risk, high burden, high complexity topics. Also, we have a variety of other programs, which you can see at the bottom of the map. We worked with health centers across the nation to implement postgraduate residency programs through our National Institute of Medical Advancement and Medical Assistant Advancement, and through our clinical e-consults network. And before we jump in with Dr. Kearney and Dr. Chanamsetti, I just want to walk through today's objectives. Identify the core and extended care team members, understand the roles of the team and how they support the delivery of care and the clinician, understand a model where systems support primary care and behavioral health, and understand the importance of supporting communication among members of the team. And I'm going to hand it off to Dr. Chanamsetti as she speaks about team-based care.
Thank you so much, Amanda. And I wanted to thank everyone who's joined today's webinar. So as Suzanne noted, my name is Veena Chanamsetti. I'm the Chief Medical Officer at the Community Health Center Incorporated here in Connecticut, and I'm a family physician by training. Have been with CHC for about 12 years, and Dr. Kearney, Tim, who will be presenting later as the Chief Behavioral Health Officer, Tim and I have worked closely together probably for the past 5 years with really a passion around embedding integrated behavioral health and true team-based care. So I'm going to speak a little bit on how team-based care can support providers and staff in your health center. So I think everybody on this call knows there's been a lot of focus on retention, and there has been a lot of focus on how to decrease burnout nationwide. And there's quite a bit of literature out there, a lot of publications on best practices and advice on what to do to really make this job in primary care and behavioral health sustainable. And while more research is needed, there are some good papers out there. Here's a couple of examples of two of them. They're easily found on the internet. And there's some guidance out there. It's important to note that the most strongly correlated factor with burnout, unfortunately, is years worked. So the more years you work, the stronger chance of burnout there is. So while you can't affect time, there are some factors that can help decrease burnout. A good study is the one that I have shown here. It's the study that the VA did, and it showed 3 main factors associated with decreased burnout. And those are, 1, having staff, providers, clinicians not do tasks that someone less trained than them could do. 2, to have some participation in decision-making in their day. And 3, that to have the medical home be appropriately staffed. So that doesn't necessarily mean that you are staffed up in provider numbers or clinician numbers, but really staffing in general and what that looks like at your health center, including support staff and admin staff. And so you can see, kind of looking at it that way, where team-based care can really support a better day for providers and staff. Before looking at what that care and support looks like, it's just important to just quickly point out and think about the infrastructure that supports team-based care and integration. At CHC, we've identified 5 key components that really set the stage for team-based care. And while, talking about each component in detail is beyond the scope of today's talk, the general process is, our infrastructure is seen here. It really starts with first the vetting and championing by leadership themselves. The leadership of the health center really has to be invested in team-based care. And then after that, it's really about aligning systems, the facilities, workflows, processes, training the frontline staff, and finally even having an evaluation to ensure that team-based care is rolling out at the sites. So these are similar to what is found in the building blocks of high-performing primary care models in the very great article noted by Bodenheimer and Grumbach. So to delve in a little bit to the roles of the team and how team-based care can support retention, it's probably worth talking about what that team structure looks like really quickly. One way to look at that team structure is by defining it by the core team members and the extended team members. So those core team members are those team members that are really on site a lot, maybe not full-time, but on site a lot. And these are the individuals that work with specific clinicians or primary care providers and really care for the full population of those providers. So basically they care for the full panel. The extended team members are those staff that have professional and ongoing relationships with members on that original core team, and they really are responsible for taking care of specific subpopulations of that larger panel. Either way, both of these team members are really caring and centered around the panel or the patients. Here's another way to look at what that may look like on site as a structure. You see that, in the core, which many people really now call the teamlet, it might be the provider, the medical assistant, the nurse, might be just the provider or medical assistant, might be the provider and the nurse, but really kind of they're the core around the full panel regularly. And then there's kind of wrapped around the panel and the team is the extended care team members, which again, because they take care of a subpopulation of the larger panel, maybe podiatrists or chiropractors, nutritionists. While many organizations look at behavioral health as an extended, I think Tim and I would argue that they are probably part of the core with the amount of coexisting behavioral health diagnoses and the coexisting screenings that happen in your panel, in your medical panel daily. They really are partners in taking care of that patient population. So let's just really quickly talk about how that core team plays a role in supporting the provider's day. So at CHC, we really have the pod design, and that core team, or what really is the medical teamlet, consists of 2 medical providers, 1 registered nurse, and 2 medical assistants. But however, in that pod, co-located and working together day to day is also what might be defined as the extended team member, and that is behavioral health. And our truly extended team members like podiatry and chiropractors are also co-located in our pod, including students and trainees. So we really co-locate the full working team, taking care of, in our case, 2 panels, because there's 2 medical providers, together in one workspace. So what that physically looks like, this is a picture of our pods in our Middletown site. Looks like a typical workspace, but what it also is, it's the workspace for both the core and extended team members. So it's important to say that there is not a nurses station at CHC, anywhere at CHC. There is not a medical assistant room or a medical assistant section. There is not a behavioral health floor or a behavioral health building. We are all co-located based on the pod design. So providers or behavioral health clinicians do not have to go looking for the MA or the nurse of the patients they are seeing. They are co-located with their team, really allowing for real-time shared communication. It can get really frustrating if you're spending your day looking throughout the building for that support team member you need. And we see that there's a clear correlation to burnout, less burnout when your team is actively engaged and proactive in supporting your day. So we will take a look, we'll talk a little bit about what that looks like, but before we do, this is a great time to just pause for a second and poll to see thoughts of our audience. And that is, my question for the audience is, do you have co-located workspaces for the medical teams and ancillary care teams and or behavioral health, but medical teams and ancillary care teams? So if you could answer yes or no to that question, we can get a sense of where our attendees are with integrated care as far as co-location.
All right, and that question should have just popped up on all of your screens. We're going to leave it open for just a few more seconds to give the audience enough time to chime in. All right, thank you very much, everybody. All right, of the people who answered, we had 60% reporting yes, 20% reporting no, and 20% reporting unsure.
Great, so that's great. It looks like the majority do have some co-location already in process, and it is a great initial and an important step for interprofessional care and integrated care. So knowing that, let's talk a little bit about what we mean when we say team-based care can support the providers and clinicians. And what we really mean, of course, is that they can, first and foremost, support their direct kind of be direct clinical support for the staff. And so the first staff we would want to look at and understand the role of is really our medical assistant, who our providers probably work closest to day to day, and really can be leveraged well beyond just rooming and doing vitals, which I think a lot of agencies have kind of taught their MAs at doing. So if you really look at a full practicing, fully scoped role of a medical assistant, there's so much that they can do to support that panel. They can be maximized in their role well beyond even just cancer screening. So of course they can ask about cancer screenings that are due, breast cancer screening, colonoscopies, but they should also be included in disease screenings like behavioral health screenings, which we'll talk about a little bit later today. They use delegated orders at CHC to complete point of care testing even before the provider enters. And they do a lot of this between much of their logistical tasks that they're doing to support the providers and clinicians. They're doing the faxing and scanning and paperwork, but they're also being proactive about the clinical care that's needed as the providers are seeing patients. Medical assistants really should also have a defined responsibility in panel management and population health, both which have been tasks that have been historically expected to be done by the provider or maybe the RN, but really the MAs have a large responsibility in their patients. This is their patients. And so at CHC, we give them 40 minutes about bi-weekly to spend some time and look and approach their panel from a population health standpoint. They can also be leveraged to support the in-between visits between providers, between provider visits. So they can support nurse visits. For example, our MAs are the support staff that are retina screening operators and will see patients between provider visits to get retinopathy screening completed, done on site. And finally, it's important to just remember that, the ultimate goal is to just engage the medical assistant and keep them more activated. You want them to be part of the larger QI initiatives, such as microsystems, and possibly even lead them and really keep them engaged at a high level, as well as the weeds of the work. A little more about planned care as done at a high functioning medical assistant. So I think the question here is really what can the provider do and what does the provider have to do? And much of what can be done or has to be done during the visit does not have to be done by the provider. We have to remember that the provider must address the chief complaint and the reason for visit. But really the medical assistant and the planned care needs of the visit can probably be done by the medical assistant. What they really need is tools and alerts to assist them in doing planned care delivery. So we have the planned care dashboard that our medical assistants use. It alerts them up to, I believe, 32, maybe 35 now items that is patient specific. It obviously includes cancer screenings that are done, but also alerts them to chronic disease screenings that are needed, such as A1C, foot exams, BMI counseling, asthma control test, HIV, hepatitis C, and also alerts them if a patient is due for depression screening or substance use screening. And using these delegated orders, the medical assistant will go ahead and complete that screening on behalf of the provider. A little bit more about the panel management responsibility that our medical assistants can do for the team. We're moving really quickly. Connecticut is more new to this, but towards value-based care and population health. And of course, our providers and nurses are laser focused on it, but really think about how your medical assistants and nurses can further support this intersection of value-based care and volume-based care, and really support the value of it. Our medical assistants, as I said, also do panel management. Our medical assistants have access to 4 clinical dashboards: diabetes, hypertension, opioid, and missed opportunities. And they can pull up their patients on these dashboards and reach out to these patients to see if they are overdue for care. So they'll be alerted for those that are due for A1C, have uncontrolled blood pressure, are on opioids but have not had a functional assessment, and they really are empowered to reach out to these patients and complete what's due. the goal of everyone's panel management, including the MAs, is really to reconnect the patients, especially those that have been lost to follow-up. This really does connect them back not only to medical, but also to behavioral health. As the MAs are reaching out in between visits, it ensures that we can try to get some control over the chronic disease, and it ensures that we are doing our due diligence to complete the planned care requirements of our patients between appointments and not only wait for the appointment. And finally, in addition, this really allows patient care to not always rely on a provider visit, but the MA can really support that care in between visits and even using the telephone to outreach. Really quickly, just the how nurses also support can support the day and support retention. Nurses provide high-level support to providers, and in many cases, they are really delivering care as an extension of the provider. Of course, their primary responsibility is to support the provider visit itself, but they also should be delivering parts of the visit to lessen the burden of the provider. So an example of a diabetes visit, for example, may look like this. The MA, of course, brings in the patient, rooms the patient, uses the planned care dashboard, completes all the screening. The RN might come in and then complete the vaccinations that are due, the foot exam that may be due, that they're all alerted to on the planned care dashboard. And then in addition, that she can also help with the treatment of the patient, like insulin titration or other treatment that may be needed, that we can have a delegated or standing order on. But the point of this is that all of this is done on behalf of the provider, even before the provider walks in. And so really it allows them to really do these visits as a team, delegated between the medical assistant and their nurse. An important way to do that between visits, of course, is standing orders. We have really a good number of well-defined, protocolized visits for our nurses. Many of these, if you look down this list, are the very visits that end up as the extra double book in the provider's already busy and booked up day. May not be acute enough to go to the emergency room, but it is acute enough that they need to be seen today, so they end up getting double booked. These are the exact visits that the RN can support the day by completing on behalf of the provider using a standing order and a protocolized template. Of course, they reach out to the provider if needed. Many times the provider will come in and touch base with the nurse and the patient, but really supports that day and not always having to leverage the provider themselves to complete simple but acute visits. And then finally, it's also very important to remember that the clinician and the provider themselves have a role in their own success and satisfaction. Team-based care does not always come naturally or even easily. And to this day, I still will talk to providers that are struggling, and I will constantly ask, is there a better way you could utilize your team? How can we leverage your team here? And it's something that we really discuss in detail as we look at the day and look at their patients. Yes, the providers are ultimately responsible for the patient, but they do need to let their team support them. They need to empower their MA and nurse in being proactive. And really, it's important to not create a culture that everything has to be asked through the provider, even if it's preventative care. A really fast example, we are in flu season right now, and many patients obviously need the flu vaccines. And we had a scenario in which a nurse, using a standing order, gave a flu vaccine appropriately to an adult who was due for the flu vaccine. And when the provider walked in, he came back out and said, "Oh, I didn't give you the order to give the flu vaccine." And she really had to politely remind the provider that she did the review of the chart, and by standing order, she gave the flu vaccine. But that kind of culture can create a tension of, can I be proactive in my care? So the provider themselves do have a responsibility in supporting that team to support them around them. And they have a responsibility to remember to leverage the team beyond vitals and just vaccines, because what they're really doing is supporting a decrease in their own burden and burnout throughout the day. And we constantly remind our team to be engaged in the big picture, especially around the roles of the panel, population health, quality initiatives, because you want to always have them engaged in the quality improvement culture of the organization. And it's important to note that, although it sounds like they are supporting the provider, all the support teams are supporting a panel, the patient panel. And so it might be the same patient that the behavioral health provider is seeing, and so they have the same support staff that can support any needs for that patient. It is really a patient-centric culture for team-based care. So really quickly, I just want to show a couple of print screens, and these are medical visits of what it looks like when team-based care meets progress note. So here's a print screen of a pre-op visit, and you can see that the MA using the planned care dashboard was already alerted to the multiple care gaps that the patient needed. In this case, they needed nutritional education, they needed hepatitis C screening, and you also see that she or he was alerted to behavioral health needs of the patient. So they completed a depression screening, a substance use screening, and a domestic violence screening using the HITS tool. Based on positive screenings, the MA will also support the reaching out and connection of behavioral health to this patient, and will reach out directly to behavioral health to support that. But it's also key to note that everything you're seeing here has been done before the provider has even entered the room. Our electronic health record is called ECW. We created smart forms for these screenings. So when we fill out, when the MA supports the filling out of these smart forms, they auto-populate the note, really reducing the burden of having to electronically enter all this information into the progress note. This is just another example of a well child visit. Again, you can see the planned care dashboard has alerted the MA to the needs of this child, including developmental screening, lead screening, vaccines noted. And you can see that she has brought in a template already and started populating that template before the provider walks in, and helps to really kind of start the documentation of what can be very long and complicated visits. So really, how team-based care supports providers is by offering a model to share the care. With each role having kind of clear roles and responsibilities, we really work to support that each role is practicing at the top of their scope. So providers, clinicians, whatever level, they are not doing tasks that could be completed by someone else. So this is really important in the kind of full picture of interprofessional collaborative practice team. And it goes well beyond just the medical teamlet. It really is how the larger team comes together to share the care and deliver patient-centered care, which ultimately then supports all providers that are involved in the care of that patient. So I think we, talked sorry, I think I'm having a little problem with the slides. Okay. So the one after this. So I think we are going to just pause, and we talked a little bit about medical, and talked about touch points of where the two integrate and how team-based care comes together, but would like to pause and do another polling question here. If we could just ask for our attendees, how many have integrated behavioral health right now at their agencies, where, and however you're defining it, but you feel that your behavioral health discipline and providers are integrated with your medical providers and with the larger needs of the patient.
All right, and once again, your poll question should have popped up on your screen. We'll leave this open for a few more seconds to get everybody's input.
Oh,
right,
wow.
Thank you, everybody. 80% reported yes and 20% reported unsure.
Well, that's great. So, Tim, I think we have a great, attendee audience here that already has a good part of integrated primary care here. So I'm going to hand this off to Tim and really talk about the behavioral health side of team-based care and how it really does kind of support the larger patient-centered care model and the providers.
Hey, great. Well, thank you, Vina. And it's great to be here with you all today. It's also exciting to hear that 80% of you are well along the way of the journey to integrated care. As Vina mentioned, and I think Amanda may have at the beginning as well, I've been here at the health center. I'm in my 21st year. And when I first came, although we had behavioral health and medical both since the very beginning of our agency, nearly 50 years ago now. When I first came, we were in separate floors, often separate buildings. And here in the Middletown site where I'm sitting today, the medical facility was on the opposite side of a parking lot. But that parking lot could have been filled with piranha. I mean, we never made it back and forth. We didn't see each other. We didn't have integrated charts. It was a completely different world. And it is a world that I would never want to go back to. Because speaking as someone who still continues to carry an active caseload of children and adolescents, that's my specialty as a child and adolescent psychologist, I used to spend so much time, not only with folks that we shared care with here in the health center, but folks outside of the health center, just trying to track down what was happening medically. And it is just so wonderful to be in a shared electronic health record and a shared environment. Just this week, I did an initial screening of a family. As they walked out of my office, the child stopped, hugged her primary care provider who was in the hall, and then the primary care provider and I had a quick curbside consult on what I saw, what she had seen, and that's, from my perspective, the way it's supposed to be. So I'll talk a little bit about how we operationalize this. As Venus showed you on one of the slides, we have in the medical section of the visit notes, section where both the MAs and the nurses are doing screenings. This is a number of these screenings. And as they're done with our patients, they will highlight who needs a behavioral health visit, preferably right there at that moment in a warm handoff setting, to just chat with them, see if in fact they need behavioral health care. Maybe they're getting it somewhere else. A lot of times those are things that are not necessarily indicated in their record, and we want to know that. We're not about stealing patients away from another provider if they're having a great relationship and they're getting what they need. On the other hand, we want to make sure that we are getting people the care that they need. And that's one of the big things that I find, and I think many of our behavioral health providers find here, when we think about what contributes to or increases job satisfaction. So that, and the flip side of that, of course, is burnout reduces and retention increases, is the idea that we are making sure people get what they need each time they walk in the door. One of my favorite hits here is that our dental screenings are being done too, so that if I'm seeing a child and they need a fluoride treatment, that's going to be taken care of right while they're there. So let me move on. Thank you. Almost. I think we skipped one. There we go. Thank you. So I mentioned warm handoffs, and I think many of you, if you're doing integrated care, are doing warm handoffs. And I made a reference in our last slide to our patient. And I think that was one of the moments when we realized maybe 7 or 8 years ago that we had turned a corner on integrated care. There are no longer medical patients or behavioral health patients in the way people talk together about the work that we're doing. They're all CHC patients, and they're all people that are here to get care. So we have both medical and behavioral health initiated warm handoff, and something that we have found to be very important. There's a danger in an integrated care setting, and I'm not sure exactly what your setting looks like. We say integrated care, but it can mean a lot of things. Sometimes people are using a behavioral health consultant model where the behavioral health provider is doing a warm handoff, a brief visit, and maybe 1 or 2 other visits, and then referring other care out to another agency or maybe another portion of the same agency. Other people do more of a integrated type model within the behavioral health department, which is what we do here, so that I may do the warm handoff, or I may do or I may receive a warm handoff from another person, but all of our clinicians are doing ongoing care also, which we have found has made a difference in our world in terms of retention and satisfaction, that people like having the variety in their day of doing both kinds of work. And as the previous slide had showed you, that our, thank you, that's okay. I've got someone else driving for me, which is very helpful. The regular type WHO that most of you are probably familiar with, we think of as reactive WHO. The medical provider is saying, hey, I need help right now. Somebody give me some assistance with this patient for whatever's going on that may be a behavioral health issue. And our schedules are set up with templates so that nearly all the time we have real-time availability, and if not, soon-time availability. However, behavioral health providers were concerned, and they raised the issue, what about the person who has a severe depression and may be suicidal, or who has a behavioral health diagnosis but never has been seen by us, or has a chronic pain, maybe they're on opioids, and we know behavioral health services would be of help. What about those people? If they come in for a sore throat, or they come in for an earache, they may not be mentioning their depression on that particular day. How are we going to get to them? How are we going to know that they need care? And that's where we built into what we call the proactive who, built into our electronic health record certain cues, and I mentioned 3 of them here. For children, we use the score on the patient symptom checklist 17, the PSC 17, if it falls within the clinical range. That if those things are the case, then can you give me the next slide now, please? Thank you. If those things are the case, it shows up here on a dashboard that all of our behavioral health and medical providers both have access to. That would tell me if, for instance, I was the person doing the warm handoffs in this particular hour, that I would be able to look at it and say, okay, at 4 o'clock, this particular person comes in and they have diabetes, and we know that there is some correlation between diabetes and the ability to do the self-care necessary and behavioral health issues, especially depression. So if somebody pops up with diabetes, we want to give them a little check. Similarly, if they're a high-risk patient, our designation for that is PCMH+. If they're a high-risk patient, if they have a behavioral health diagnosis, those things that I mentioned, if they're getting medication-assisted treatment but not in behavioral health care, all of those things, we're going to walk in, and as a behavioral health provider, I'm going to come in and say, hey, you may not know that you have a behavioral health provider on your team, but you do, and I'm him, and I just wanted to touch base with you. Your health record shows that you may be at risk for, and I'll fill in the blank depending on what the thing is, and I just want to touch base. Are you okay today? At some point in the past, your answers indicated that there might be some concern in this area. And we're finding about 80% of the time people enter treatment, and the rest of the time, no, but they've learned that there's treatment available, or we're able to indicate in the record that they're getting treatment somewhere else. So it's really a win for everybody, and it increases satisfaction for both the medical and the behavioral health providers, because we have a better sense that as a team, we're really taking care of our patients. So here's another shot of our integrated health record, which Mina showed you before, and presumably all of you have something like that you're working with, maybe EHR, maybe another system. But the important point for us here is that all of the data is accessible bidirectional. The smart forms that Vina mentioned, whether it's the HITS, domestic violence screening, or an expert screening for drug or alcohol, or depression screening, whatever it is, that I'm able to go in and look at that data and see what the person scored and be able to talk to them about it, even though it may have been our medical colleagues who gave the evaluation themselves. We're able to share care plans, and we have electronic referral and recall process that goes back and forth, and a collaborative care dashboard, which I think is our next slide. Nope, we already did the collaborative care dashboard. Sorry, it was our previous slide. But what we do have also that we have found to be very important is an integrated scheduling system. All the calls go to the same call center or the same scheduling agent. That if somebody calls in, they got the reminder call, needed to come in for a dental appointment, and they need to see me, the person who answers the phone call is going to say to them, hey, it's great that you've called the schedule for your dental follow-up, but I can't help but notice that you're supposed to see Dr. Kearney. And what would you like to schedule for him right now, or vice versa, whatever the issues are. And again, I love not having to worry about that. Certainly if someone has no-showed an appointment for me, I'm going to go ahead, I'm going to make a call, I'm going to try to reach them, I'm probably going to leave a message on the machine, but that I couldn't get a hold of them. But now we have a system in place so that when they do call in, for whatever reasons, the person who gets the call knows what needs to happen, and it's visible right there at that point of contact. And hopefully we're able to go ahead and hook them up. There's the collaborative care dashboard. I'm sorry, I was out of order. This is a dashboard that's available for all of us in behavioral health. And each day, this comes up on our screen, and we can look and see various things. Is this person on a controlled substance? And do they have a controlled substance agreement in place? And if not, it turns red for us. Does this person need a PHQ? We do the PHQ on an annual basis as a screening. And we're actually about to move into a process where we're going to do it quarterly as an outcome measure too. But currently we're using it as a screening, and a red box indicates that person hasn't had a screening recently. and so forth. It's a way that when someone comes in to see us in behavioral health, which they do more frequently, typically, they're usually coming in every week, every couple of weeks, they may see their medical provider much less frequently, we are able to make sure that the planned care that is being provided by the medical folk, where appropriate, we can step in and we can make sure that planned care aspect is being taken care of. So a couple of other things, group therapy. Our behavioral health world shows tremendous results both for adults and for children, because it's one thing to be able to sit and talk to an individual therapist, whether it's adult to adult or adult to child, but it's quite another thing to be able to talk to peers and build support systems. Our clients tend to be socially isolated, both because of their mental health issues and because of other social determinant of health issues. And we want to build in and encourage opportunities to meet together in groups. So our medical team is helping us identify and refer people to groups. Here are some of our typical groups: smoking cessation, chronic pain. Suboxone groups is part of the integrated MAT, medication assisted treatment. And the model there is that the medical providers will initiate and provide the Suboxone treatment. But as part of the Suboxone treatment, in order to get the vouchers that will enable them to get their medication, they have to attend regularly a behavioral health group to help them identify triggers, maintain their sobriety, and so forth. And that has worked out really well as a model. We have about 28 Suboxone groups running through our various parts of the agency right now. We also treat mood disorders and trauma in group as well as individual. So another big aspect that we have got going at every site right now, and if you have been able to, haven't been able to get this in place, I would encourage you to look at it. It is one of the factors that our staff most frequently cite when asked about what parts of their job they are most satisfied with. And that is an integrated care meeting. We have at least one a month at all of our sites, facilitated by a behavioral health care coordinator. And we select the patients from a risk stratification list that have chronic diseases as well as a behavioral health condition. So right there, it's an integrated issue. And the goal of the meeting is to close any care gaps and to reduce preventable ER utilization. So the PCP, the MA, the RN, the behavioral health clinician, and an access to care worker discuss 7 to 10 cases in the course of an hour and really go through the record, go through attendance, go through unresolved referrals, all those things in order to document what has to happen as respective or appropriate for each one of their roles. And all that is entered into the healthcare record in a global alert that has the recommendations to follow up. And then the behavioral health care coordinator follows through to make sure that I said I was going to call the hospital, that I really do it, or whatever else the issues are, to make sure that stuff happens. And now beyond the team, there's lots of other support for providers. Again, a very powerful thing on retention is folks telling us that they appreciate the fact that we take education seriously and professional development. So we use things like our Project Echoes, continuing education support. All of our staff have, in the behavioral health world, all of our licensed staff have 3 days a year because that's what's required for licensing here in Connecticut, and $1,000 to support them to go out and get additional training in behavioral health aspects. The medical staff, the psychiatrists, and in Connecticut, psychiatric APRNs are independent practitioner license level. Both of those get a little bit more time and a little bit more money because they fall under the medical system, not because we value medical more. That's not why we give them more money. It's because for their licensures, they're all required to get 5 days of training. So we have to give them a little more time and a little more money to go out and do that. Many of our staff love to teach, whether it's clinical supervision, precepting in the medical world. We use the medical term. That's another interesting thing about integrated care, isn't it? How much our worlds are different. We use different terms, but kind of figure that out as you go along. Opportunities to teach, opportunities to do research, opportunities to be involved in quality improvement. That all keeps your staff alive and excited and gives them a little bit something more to do than just patients hour by hour. So, in conclusion, let me wrap up so we have time for questions. It's very important from the very beginning to find the roles and responsibilities of each team member so that everybody knows what they're doing, and not only what they're doing, but what they can count on their colleagues to do. One of the worst feelings is to know that there's an issue beyond your scope of practice and that you're not going to be able to take care of this person. So you've got someone else there doing it for you, which makes you feel a whole lot better. And as Vina mentioned also, the importance of people working at the top of their license and that they're trained to do that. There really is no reason why a very trained and experienced behavioral health clinician ought to be doing the kind of work that somebody else could do and maybe even do better. And so we are trying to be very careful about that we assign the right tasks to the right person. And it's interesting what the slide says, because I was almost going to say other words until I read it, which is build an individualized professional support system for clinicians, which we certainly do. But I was going to say an individualized professional support system for patients, which is really what it's all about, but it amounts to the same thing. So we are just about done with my section, so I'll pass it back to questions. And I'm seeing a comment that my mic may not be working, so I'll take a look at the connection while we go on to questions.
Okay, so now would be the time if you have any questions to go ahead and jump in. And if you have any questions for any member of the Community Health Center Inc. team, I'm sure they would be thrilled to answer any questions that you guys have. Okay, well, it doesn't look like there are any questions at this time. If there's certainly anything that comes up afterwards, let us know, and we would be more than happy to direct your question to the appropriate party at any time. So, so take a minute to digest all of the great information that everyone has shared today. And again, if you have anything that comes up, or you think of anything, certainly let us know. So what's next for everyone? We do have some discussion board questions on the discussion board. So they are really to get you thinking a little bit more about what everyone, Dr. Chanamsetti and Dr. Carney talked today about. So go over and check that out. And then also to please complete the post-series survey. We are always looking to strive to serve you guys better and see if there's anything that we can do better on our next series. So with that, we thank you, all of you again for joining us today, and the team at Community Health Center Inc. for a fantastic presentation on team-based care and also integrated behavioral healthcare into the team-based care setting. And we wish all of you happy holidays, and we will talk to you guys soon. Take care, everybody.
Thank you. Bye-bye.